So hello, everybody, and welcome to our program tonight. Our leader of discussion is going to be Eric Fishbein, who's going to tell us about Medicare and how to choose the appropriate Medicare program for you. Eric Fishbein is the Assistant Vice President of Managed Care at Virtua Health, one of New Jersey's largest not-for-profit health systems. Eric has 2 decades of experience in managed care consulting and contracting, working with various insurance companies and healthcare organizations. He holds a BS and an MS in economics from Lehigh University, a Master of Health Administration from Cornell, and he's a fellow of the Healthcare Financial Management Association. And Eric, I turn this over to you.
Thank you, Helene. First of all, thank everyone for coming. I know I'm competing against the Phillies, so I guess it's a pretty high honor to have everyone here. So also, if you hear some screaming in my house, that is probably the root cause of that. But I have some slides here, which I will run through. But I do want to keep this somewhat informal. There's not a ton of folks here, so feel free to take yourself off mute or put your hand up or shout or something if if there's a question throughout, but certainly can leave it open for discussion at the end as well. So let me try and share my screen out here. All right. Can everyone see my screen here? We're good? Okay, perfect. All right. Work. Okay. So here's a quick agenda I have here. A little bit about me, which Helene took care of, so thank you. I want to talk a little bit about the basics of health insurance, kind of level set as to what health insurance is all about, Medicare specifically, and then dive into traditional Medicare, Medicare supplements, talk about Medicare Advantage, and then just some general considerations and tips. So we'll start diving in here. So Helene talked a little bit about me. I guess, why I thought it was important to have this class and offer it is just about 2 years ago, my then boss, she had my role at Virtua. She had been at the role for 30 plus years. She had turned 65. She was, still working, and then she retired at 67. And she was scratching her head trying to figure out what she wanted to do as far as health insurance. And I sat there and thought that, someone who has 35 years experience doing this and scratching her head trying to figure out what to do, it has to be overwhelming for the average person who is either turning 65, at 65. That's further compounded by the fact that, you can't turn on daytime TV without someone sitting there telling you this is the greatest plan, right? And this is what's perfect and this is what you need to do. And I think it's really hard to make those decisions. So I'm trying to give some unbiased advice here, right? So I'm not an insurance broker, right? So I'm not licensed to sell anything. So take what I'm saying, for whatever it's worth, right? I can't sell you anything. But I'm just trying to make you a better informed consumer, right? Give you some background on Medicare, hopefully answer some questions. As I said, I want to keep this somewhat informal, so feel free to ask questions throughout. I tend to speak ridiculously quickly. One of the things I need to work on, so feel free to yell me to repeat or slow myself down if I am going too fast. And also if I'm just using too much jargon, right? I tried to define some terms early on here, but if I start talking about stuff that makes no sense, again, just put your hand up, kind of stop me, and we'll hopefully make sense for everyone. So I think we'll dive in here. Is my screen cut off by the bar? You guys can see everything on here. This is okay? Okay, good. So just basically, right, insurance, right? What insurance is supposed to be about. So take health insurance out for a second, but overall insurance, right? It's supposed to be for high cost, unpredictable, and low frequency events, right? That's what traditional insurance is. If you think of your home insurance, right, that's exactly what it is, right? It's not for your everyday repairs, but if your house is burglarized, there's a storm, a fire, something like that, you pay a premium for it. We'll talk about what a premium is in a second, right? And if there's a big catastrophic event, you get paid for that loss, so you don't bear the cost of it, right? That's kind of how insurance is supposed to work. Health insurance is different, and it's weird, right? Because it's not like traditional insurance, because it's a mix of predictable and unpredictable, right? You may never know that, when you're going to be hospitalized and something catastrophic is going to happen, but I certainly know I'm going to have an annual well visit to my doctor. And if you have a specialist, you may visit them quarterly. And to a certain extent, you may even know what those things cost, right? So it's weird in that regard. It's also weird in the fact that spending money today, right, can potentially save money in the future. So if you think about preventative care, right, that's the whole goal behind it. Like, other than like on the personal level, right, to keep yourself healthy and live as long as you can and be as productive as you can. From an insurance perspective, they're sitting there just counting dollars and cents and sit there and say, hey, if I do a mammogram today, I can prevent someone from having a cancer 5 years down the road, which is a lot more costly to treat, right? So it's kind of this weird mix that's there. Again, I mentioned it's also high cost and low cost, but it's also a little bit odd in that the individual, you may have more knowledge of yourself, right, than the insurance company. They can look at, and data has gotten better, so I get all that, but they may not know your family history all that well, right? I may appear perfectly healthy on paper, but genetically, like I look terrible based upon my family's risk factors, right? That's very different than me. I really have no sense of like my home insurance, right? NJM does a pretty good job. They know the area I live in. They know the flood risk, right? They know up in storms. Like I can't figure all that stuff out. Health insurance is a little bit different in that regard, right? The other thing that's weird about health insurance is that you can't decide for yourself generally, like what's going to be done for you, right? I can't decide that, oh, I want a surgery, right? I want a CAT scan even, right? Most of that stuff, you're relying on a doctor or a nurse practitioner or some kind of provider to decide what's appropriate for the care you're given. And we're not really in a position to determine whether that's good care, whether it's valuable care or not. There's some push towards like consumerism, right, to make people feel more the cost of it. But the reality is, like, it's hard for us to evaluate whether something we're being prescribed is worthwhile or not. We're relying on those doctors to do it. And the other part here that's kind of, again, unique to health insurance is it's just as much about bearing risk, right? That you pay a monthly premium or an annual premium there, and discounts, right? I'll show you. I have a slide. Actually, it's the next slide I have. But it's health insurance is healthcare in general is obnoxiously expensive. It is hugely expensive, right? So beyond just bearing risk, right? It's a discount, right? What I do in my day by day at Virtua is I negotiate with insurance companies and the hospital, right? I'm trying to get paid as much as I can for the services I deliver. And the insurance companies are looking to negotiate the lowest rate that they can, right? So insurance companies not just helping you to spread out the risk over a bunch of different people, they're also negotiating discounts with volume as well. The thing that's kind of interesting about Medicare as well is that Medicare was actually designed in the 1960s, right? And it's evolved over time, and a lot of it isn't really, it's evolved, I guess, from a provider perspective. It has not changed a ton from a consumer perspective, right? There are innovations, a lot of that is Medicare Advantage, but the way it was set up in the 1960s, a big piece of that still takes place today. So that's kind of one of the, it's kind of a little bit out of date, but it's also some benefits to that. Just to kind of give you a sense of, and I don't know if you guys can see the screen here, right? These are two things I pulled that we actually have in my office here, right? So this is hanging up in my boss's office, the one on the left. This is a bill from, it's now Virtua Mount Holly Hospital, but it's from 1924, right? And this person was in the hospital, I believe it was 16 days, right? And the total cost was $103.25 that was there, which I believe was paid cash, right, at the end, actually before the patient was discharged, right? Flip to the right, this is actually a bill, I tried to find a patient, I blinded the information so you wouldn't know who it was, right? But this is a patient that was here this summer at the same hospital, right, 2023, for 16 days. I don't know if you can see in the top left, top right up here, but this is just page 1 of 18 of this bill, right, that is here. Total charges for this stay were $370,000 that was here. I'll also point out, if you look at the last line on the bottom here, one lab test we delivered in the ER cost as much as the whole hospital stay right back in 1924. So I guess it's a way of saying healthcare has become increasingly complicated and increasingly more expensive, right? So just to kind of level set, right, where we are today with health insurance. Okay, so before I dive in too much deeper, just like some general terms I'll probably throw around throughout. And feel free to ask questions on these if I don't do a great job of defining them. Premium, right? So that's the amount you pay for insurance, right? Every month, annually, however it's set up, that's there. A deductible, right? That is a certain amount you must incur before insurance kicks in, right? So all types of insurance have it, right? Homeowners insurance, auto insurance, right? You crash your car, $5,000 worth of damage, you have $1,000 deductible, you pay the first 1,000, right? The insurance company pays the next 4,000, right? Essentially, that's how it works. Same thing on health insurance as well. Copayment, right? That's just a flat amount you pay for a certain type of visit. Maybe $20 to go to a primary care doctor, $40 to a specialist, $100 to visit the ER. It all depends on how the plans are set up, but those are flat amounts that are in there. And then coinsurance is a percentage of what the insurance company pays, right? So you go to the doctor, bill is $100 that the insurance company says they're going to pay for this because they've negotiated that rate. You have a 20% coinsurance, you pay $20 of that, the insurance company pays $80 of it, right? All these, I guess, have a couple of different purposes, right? Part of it is to make you bear a little bit of the cost of it, right? So if it costs you nothing, you have an incentive to use the doctor for every single sniffle that you have, right? But if you sit there and say that, oh, you know, this may cost me some real money, maybe you won't go to the doctor for unnecessary things. Good and bad for that, right? So that's a good thing if you're not going for every single sniffle. It's a bad thing if you can't afford to go to the doctor when you're acutely ill and you get even more sick, right? So that's one piece of it. The other part is that, you know, reality is it's less money out of the insurance company's pocket, right? So these things can work together, right? If you have more out of pocket for each time you use healthcare, the insurance company is going to pay less, you're going to pay more. Theoretically, your premium should be less as a result of that. We'll talk a little about designs in a minute, but the one thing that's kind of, again, kind of quirky about health insurance, right, is a lot of these things work together, right? So sometimes you go to the doctor, and depending on the plan you have, you could have a deductible, copayment, and coinsurance all happening on one particular stay, right there, or one doctor's visit. So they're not mutually exclusive, but they can factor into every single one of the visits they have. Another item which kind of gets thrown around are charges versus an allowed amount, right? Charges are like a sticker price, so that's what doctors or hospitals charge, right? So if I go back one slide here, right, this $370,000 here, right, that is virtuous sticker price for this person's stay. I will tell you, we do not get $370,000 from anyone, period, for this stay that's out there, right? We, you know, the insurance companies negotiate discounts. If you don't have health insurance, we have self-pay discounts, but that is quote unquote like our sticker price, right, that we pay. The allowed amount, that is what insurance companies have negotiated, or the federal government has said, we're going to pay for a type of care that's delivered. Maximum out of pocket, right? Insurance will put, you know, does want to limit the amount you have to pay, right? Otherwise becomes not particularly reasonable. So generally there's an amount in there over the course of the year, right? There's a maximum out of pocket amount. So you won't spend any more than X, right? You could add up all your $100, you know, co-payments that are there and your co-insurance, and they may sit there and say, on no year will you spend more than, you know, $5,000, $3,000, whatever it is, just to provide you some protection so it's not prohibitively costly. And the last two terms are probably two sides of a coin, but prior authorization referrals. Both are ways to control utilization, right? Prior authorization is an insurance company looking to say, what do you need to do, right? They're evaluating the care that the provider says they want to give you to make sure it's medically necessary, right? To make sure it's appropriate, it's the appropriate location. And that's usually facilities, right? So doctor said, you go to the doctor, say, hey, I have a headache. I've had continuing headaches. The doctor says, I want you to have a CAT scan. The insurance company may sit there and say, great, before you have a CAT scan, we're going to have to review this to make sure you've done less invasive stuff that's clinically appropriate. And referrals are if you're in a plan where you have to have a primary care doctor to make sure that it's kind of like they call it like the mother may I, right? Before you can go see a specialist, the primary care doctor will have to sit there and say, hey, we've approved this, you can go see the specialist. We feel, you know, it's appropriate. A couple of different rationale for that, you know, allow the primary care doctor to always check in on you, to contain costs, but just another option. So I'll pause here for a second. Any questions at the moment before we dive into any more detail? So Medicare eligibility, right? I just want to kind of level set, right? So Medicare, and I guess the point I want to drive home, right? It begins at age 65. There's also, again, kind of, your experience may vary, right? There are certain disabilities, like if you're permanently disabled, you're on dialysis, right? There are other reasons why you can come in, but by and large, for the average person, most seniors in this country, when you turn 65, you become eligible for Medicare, right? The point I want to drive home, this is not Social Security retirement age anymore, right? I think what's the full age for retirement now? 67, something like that. It's increasing every year, right? You can still qualify for Medicare at age 65. And traditionally, right, when people getting ready to turn 65, go to Social Security office, sign up for everything. And that break has caused people to kind of miss their enrollment. So if you are turning age 65, do not miss your Medicare sign up. I guess that's one of my takeaways, right, that are here. If you're still working, you need to have conversations with your employer, what that looks like. If your spouse is still working, you need to have conversations with their employer and see what that looks like, because there are many complicated rules around when you can sign up, when you can't sign up. But if you don't sign up at age 65 and you don't have what they call credible coverage, which most, I'll call it normal health insurance, qualifies as credible, that's out there, there's going to be a penalty. It's going to cost you more each month when you sign up. So if you're turning 65, make sure you understand what your options are with regard to Medicare.
Hey, Eric, so I understand you need to sign up was it like 2 or 3 months prior to you turn 65?
I believe so, yes.
Okay, but so if I'm still working when I turn 65, so I can choose whether I take Medicare or my company healthcare?
So if you're still working, you need to speak to your HR department and see how their plan is designed, right? Some plans kind of force you to sign up for Medicare as a result, right? Others, they will become secondary. It really depends very specifically on the plan that your employer has chosen. The richer benefits, right, will typically allow you to keep working, right? If you plan on continuing to work for a while, and they will continue to fund it, and you should also look at the cost, right, which you're paying out of pocket, as an employee, right? And costs have gone up. You have to kind of look at all that together. Some will force you to sign up for Medicare. Some will allow you to continue. It is really like employer specific. And then if you have the option, right, you need to look at the cost of, what's costing you, what that benefit are versus what Medicare is.
Thank you.
All right.
Eric, if you don't mind, can I just kind of piggyback on something that Leon mentioned about signing up for Medicare? For 65, it's 3 months before your 65th birthday. You're the month you turn 65 and 3 months after. So you've got a period of time. And I'm sorry, I'm just sharing some experience because I worked in benefits for a health system and have some familiarity with this. I don't mean to take anything away, and I'm over 65. So, what we used to tell our retiree or people who were still working at 65, since they were able to stay on our employer's coverage, like what you mentioned, Eric, we always suggested that they get Part A because it's free. If you can stay on your employer's, you would stay on your employer's, but A is free. And then just stay on your employer's and get B once you leave your employer. But what you said is a good idea to ask your employee benefits department.
Because there are all sorts of rules. I don't pretend to be a coordination of benefits expert, right? But there are all sorts of rules around how Medicare interacts with your insurance, whether you're working, whether you're not. So it is very individual that's out there. But generally, you need to kind of have those conversations and start doing some math.
Yep.
Blythe, I saw you had a question.
No, I just wanted to.
Oh.
I'm sorry.
What I wanted to say was that by some fluke,
I ended up not realizing that I was eligible, and that women have a different eligibility than men. And so I applied a year late. And so I have never gotten the full amount. They could only take me back a certain amount of time. So really listen to what he's saying about applying in a timely fashion, because otherwise you'll lose money.
So I wanted to add to what Arlene had said earlier. I went to another session just recently, and they said when you were still employed, still working, and have insurance, that 3 months before your birth date and the 3 months after your birth date is not relevant to us because we are still working with insurance. However, before you retire, you need to then apply for the A, B, and supplements, etc., before you retire.
Yeah, so again, it is very dependent because large employers especially can write their benefits however they want. There are laws around it, but they can be pretty flexible with it. And some will, I kind of previous life, right, prior to my current job, right, we used to work and find overpayments, right, related to insurance payments. And there were ones that were set up based upon regulations where if you didn't take Medicare, they treated it as if you took Medicare, right, whether or not you signed up or not. So they would treat themselves as they'd only pick up, and we'll talk about what Part A covers and Part B covers in a minute, but they would treat it that way. So I think the real takeaway is if you are still working and you're turning 65, make sure you have a conversation with your HR department and really understand what the requirements are, what's expected of that, because you can end up saving yourself a lot of money or costing yourself a lot of money just by some of those decisions that you make. So I want to talk about the Part A and Part B. And I think, Arlene, you just mentioned a minute ago, right? Kind of Part A doesn't cost you anything. And to a certain extent, that is right. It doesn't cost you anything additional, right? You've paid for it your whole working life, right? As long as you're working, and it's 40 quarters of coverage, right? Which works out because not everyone earns, right, consistent amounts each period of time. Basically, if you've worked for 10 years, you will qualify for Part A in a nutshell, right? That's kind of how it's set up. Again, there are always differences based upon that. Part B coverage, though, you pay for that once you start taking Medicare, right? And so I put the premium numbers up here, right? It's not insignificant, right? I think $165 per month, right? Generally is the number in 2023. I did not look and see what they are for 2024 yet. There's going to be some inflation factor based upon that's out there. But that also varies based upon your income as well. It could be up to $561 a month. Again, not insignificant, right? Depending on your income that's out there. Also, just something to consider, right? The year that you retire, they're looking back, right? So if you had a pretty good couple of years, right, prior to retirement, income-wise, those first couple of years you're in there until those adjustments take place, you'll be paying quite a bit for Medicare Part B. So just, as you're thinking about that retirement, I would not bank on that $165, right, that first year into retirement, and you're sitting there thinking about your income is. It may be higher, right, because it's based upon prior income. On the other end of the spectrum, right, just a couple of things to think about. If you do qualify for Medicaid, it's going to kind of help with some of the costs with it, adjusted annually. I think the overwhelming majority of seniors end up having this deducted from their Social Security payment each month, right, just kind of out of sight, out of mind. You just, you come home net less from Social Security. So I'll talk a minute about the differences between Part A and Part B, but just wanted to kind of lay those out there as well. Okay, so here are the Medicare parts that we have. And I'll dive into a little bit more detail on each of these in a moment. But the way, I guess, to think about this, and again, this is kind of the construct when Medicare was created in the 60s, right? There was, for those who remember when Blue Cross and Blue Shield were two different companies, right? One was for doctors, one was for hospitals. That was kind of the construct under which Medicare was created, right? At a real high level, and there are nuances with this, but Part A covers hospitals, right? It's facilities, inpatient hospitals. That's what Part A is. Also carries, for nursing homes, and there are restrictions around when that qualifies. Home care, hospice. One point I will make about nursing homes, though, and I just want to make sure everyone's clear on this. Medicare does not pay for long-term skilled nursing care, right? It pays for after a hospitalization. You need to be in the hospital, I believe it's 72 hours under traditional Medicare, so 3 days in the hospital, and they'll pay for a period of time. But if you think about people that are chronically in skilled nursing facilities, Medicare does not cover that, right? So that's what long-term care insurance is for. Ultimately, people dip into their savings if they qualify for Medicaid, but Medicare Part A does not cover that. Generally, Medicare Part B, right? It covers doctors and outpatient hospital care. So, you know, if you go to the ER and get discharged, radiology tests, lab tests, things like that, that all falls under Part B. And Part C and Part D, I will talk about in a second, a few minutes, right? Those are the Medicare Advantage plans, which are options, right, that are out there. Like a traditional HMO or PPO plan, commercial insurance. And Part D is the drug benefit, right? So, which you may or may not need depending on your circumstances. And we'll talk about Medigap and supplements as well, right? So those are all different parts of Medicare in this complicated system we have created. Okay. So traditional Medicare, again, nuances, other things it covers, but traditional Medicare, right, hospitalization, if you think about it like, hey, you get admitted to the hospital, right? Probably the most common scenario for Medicare Part A being used. What does it cost you, right? So you check into the hospital, if you're there, you know, overnight, right? $1,600 deductible, it costs you $1,600. And that's all it would cost you for the first 60 days you're in the hospital, right? That you have, that's there. Days 61 to 90, if you happen to be there for that long, which is a really, really long length of stay, right? I think the average length of stay in the hospital is probably 3 or 4 days at this point, even for Medicare patients. But there'll be a $400 copayment each day. And then if you're there beyond day 90, they have a lifetime reserve days. Again, part of the details that are in here, but there's an additional copayment for each day that's in there. And after you've exhausted those days, it's up to the recipient to pay those. So that's how traditional Medicare works. Part B is coinsurance, right? You have a 20% coinsurance after deductible. So $226 if you visit the doctor twice during the year, you're going to hit your deductible, and then you'll have 20% coinsurance, right? So 20% of what Medicare would allow is in there. In the interest of trying to keep people healthy, though, Medicare does waive their cost for certain preventative services, like flu shots, COVID testing, colonoscopies, mammograms, things like that. I'm going to take a moment here, probably completely unsolicited, to encourage everyone who is 65 plus. I'm not a physician, but please do get your flu shot, COVID updated boosters, RSV vaccine. I know I'm going to be controversial here, but do it. Like, just do it. Especially if you have Medicare, it doesn't cost you anything. Do it. So,
Can I ask a question, Eric,
sure.
before you continue? So I apologize if this is like a silly question, but I am confused. So initially, Part A, we were told there's no charge. Part B, we do pay. But when I look at this, so it's $1,600 deductible for the year.
That is, so this is for each stay in the hospital, right? So that Part A, where you said there's no cost, that is for the insurance. But this is your cost if you end up in the hospital, right? So if you end up Part A and you never end up in the hospital during the course of the year, you wouldn't pay anything for Part A, right? But if you do end up in the hospital, you would have that $1,600 deductible for when you get admitted. Does that make sense?
Not really, to be honest.
Okay.
Because, so what I wrote down earlier is hospitals and home care is covered by Part A, and Part A, there's no charge. Well, I was confused by that because obviously there's a bill to be paid. So now I'm looking at it. So there's a $1,600 deductible if you were there for how many days?
It's for up to 60 days is the cost for it, right? So the no charge, I'll just go back here a second, right? That is the premium, right? That's the cost of the insurance, right? For the insurance itself. So take health insurance out for a second. Think about your homeowner's insurance, right? You have to pay your monthly premium that's there, right? The $1,600, right? That is if you actually have a claim, right? Your house catches on fire. That is the part that you would have to pay before the insurance kicks in. So the $1,600 would get billed to you if you checked into Virtual Memorial Hospital of Burlington County. If you checked in and you were there for 5 days, we would send you a bill for $1,600. Medicare would take care of the rest. Does that make sense?
Yeah, that makes sense. So if you're there between days 1 and 60, is there still a deductible? Yes.
That one $1,600 deductible if you're there for the first 60 days.
And if you're there after 60 days, then there's a $400 copay for each day.
That is correct.
In addition to that $1,600 deductible.
Correct. So if you were there 61 days, you should get a $2,000 bill from the hospital. That is correct.
Okay. So hypothetically, you go to the ER, you're admitted into the hospital, you're there for 2 days, $1,600 deductible. 2 months later, you're in the ER and they keep you. That's another $1,600 deductible.
I should clarify that. I probably need to investigate. I don't remember if that's $1,600 per year or per hospitalization. I don't remember off the top of my head, to be honest with you. So
okay.
I can that and let you know, but I don't remember off the top of my head. It may be annually. Charlotte, did you have a question?
Yeah, I am a little confused because back in 2013, well, first of all, is this $1,600 deductible something new?
It's varied from year to year, but it's been north of $1,000 for as long as I can remember, right?
Okay.
So
the only reason I'm questioning, back in 2013, I was obviously on Medicare then. I was at the hospital for several days with pneumonia. I would have remembered if we had a $1,600 deductible.
So I will flip ahead one slide here, right? And I don't know if you happen to have a Medigap plan, but my comment is going to be
That's it. Okay.
So you look at this and say, wow, $1,600 is a lot of money, right? Or 20% coinsurance is a lot of money, right? If I'm going to the doctor or end up in the ER that's out there. And you say, that's a lot for me to stomach all at once that's out there. So Medicare has what they call these Medigap plans, right? If you opt for traditional Medicare, right? And hopefully you can read this chart here. But essentially, right, these are things to kind of help fill that gap, right? So you're not responsible for that $1,600 or 20% or whatever they are. These are all, there are hundreds of companies offer them. I guess the good news on here, right, they're just lettered A, B, C, D through, well, then F, then G, then K, then F, but they're all, right, this is kind of a summary chart of what they offer that's out there. And then certain ones aren't offered now, right? F and C aren't available for new people that's out there, but you can kind of renew them, right? Essentially, right, but these are ones to kind of help fill that gap, right? So you're not responsible for perhaps that $1,600 or 20% coinsurance, right? So if you happen to have that, right, in addition to your traditional Medicare card, when you go to the doctor, you present them with that supplement card, right? AARP offers one, AAA offers one, all sorts of organizations. And then the same companies that offer Medicare Advantage plans, which we'll talk about in a couple of minutes, offer them as well, which I know it's confusing, right? Because Blue Cross offers 20 different items, right, that are here. But you can this helps if you have traditional Medicare, right, to cover those additional costs. So again, you know what you have, right? There's a cost with them. There's no doubt there's a cost with them, but that's a predictable cost, right? So you're not hit with those unexpected expenses that are there. I guess the takeaway on these is that they are all identical, right? Everyone that offers like Medicare Supplement A, the benefits for that are exactly the same, but they're priced for you, right? They look and say, where do you live? How old are you? Right? And we're going to sit there and offer the same benefits. You can shop on cost. I think the one thing, I guess, again, kind of the takeaway from this one, though, is when you turn 65 or initially enroll, right, you can pick any one of them that can't refuse you. But if you have opted, once you've already been enrolled in a plan or been a Medicare Advantage plan, there's no guarantee that these plans will pick you up later down the road, right? So if you sit there and say, oh, Medicare Advantage is a great deal, it's cheap now, you're 65 and you're perfectly healthy for the next 10 years. And then at age 75, you realize, I'm getting a little bit sicker. This is kind of a pain. We'll talk about some of the things with Medicare Advantage in a minute. I think I want to opt into one of these Medicare supplement plans. There's no guarantee these plans will accept you, right? It's like any other kind of insurance. They're weighing the risk for it. So it's something to think about, right? If you can, I guess, if money is, if you feel that you look at it and say, hey, I can pay my Part B premium, right? I can deal with these Medigap plans. That certainly gives you the most flexibility, right? I'm going to pay this each month and perhaps have to worry about very, very little additional unexpected costs, right? That are out there. That is the way to do it, but it's expensive, right? These plans can get pricey for doing it, but if you can afford it and you like that flexibility, this is certainly something that's out there.
Hey, Eric,
Sure, yeah.
just real quick, we did a quick Google. It appears that 1,600 deductible it says per benefit period. It seems to be a year.
That's a year.
Because in 2024, it's going to 1,632.
Okay, thank you. So that 1,632 is actually supposed to be the average per diem cost in a hospital during the course of a year, right? So theoretically, nationwide, that 1,632 is the average cost of a day in a hospital in this country. But so it's annually. Thank you, Leon. Charlotte, did you have another question?
Yeah, I'm glad you mentioned it because the ACA does not apply, as you just said. There are pre-existing conditions. And so it's a whole different ballgame for Medicare than it is, out there with other insurances for people who are on Medicare. And I don't know that everybody realizes that.
Yeah, I mean, it's kind of like it's going to layer by in the headlines, right? You kind of sit there and there's a headline, there are all these, the top 10 drugs, right? They're not going to cost more than $35 a month, whatever is out there, right? Well, that's 3 years down the road for a handful of drugs that are out there. It doesn't really help you if that's not the drug that you're on, or if it's 2 years from now, right? So, you have to read beyond the headline, right? to see what's happening.
I have a question. When you mention that individual plans can refuse coverage based upon your health history, so many of us we're getting inundated with various Medigap plans, so all of those plans, if we were to choose any one of those, not the Medicare supplemental benefits, but we go to an independent insurance, are you saying that any of those could also, in a sense, drop you?
So these are so once you're enrolled, they can't drop you from them, but they can not enroll you, I guess, for these Medigap plans that are there, if that makes sense, right?
Not enroll you initially, you mean?
Initially, so if you did this when you turned 65 or lost your credit or lost your employment coverage that's out there, they can't refuse you. But if you don't have one today and you've already been enrolled in Medicare, they do not have to enroll you. What they're trying to protect against is, I've been perfectly healthy and haven't, just had my Part A, Part B, I've been perfectly fine. And then I realized I got really sick towards the end of 2023. Next year is going to be a disaster for me, right? I know it's happening. They're trying to protect against me enrolling, right, just before I'm going to have high costs. They're trying to protect themselves. It'd be like, I crashed my car. Now I'm trying to sign up for auto insurance, right? They're trying to protect against that. So like for the ACA, right, the reason why there's no pre-existing conditions anymore, right? Theoretically, we can talk about politics, right? You need to have insurance now, right? Everyone needs to have it. So I couldn't go uninsured on the commercial population. For this piece though, right, you were bearing the risk of this health insurance up until you chose to sign up for it. If, and once you turn 65, it's kind of, you're open, but they don't want people signing up when they feel they may have a high risk for it. Good. What?
So if one is a government employee or you're under a large company and they're offering benefits for you and limited choices, these plans that you're referring to here, is that something in addition to that? Or would that normally be a part of something that a government HR office or a large company would be offering?
So these are usually not available if you have those, right? So there are a couple of different scenarios that are there. So like the state of New Jersey retirees, right? They have, right. I'm going to guess that's what we're talking about, right? So they have opted. Well, they have a couple of options now, but I believe Aetna is the right, because that's who I deal with at work more often, right? They have opted for Aetna to be their primary carrier, right, for their Medicare Advantage plan. And really, that's the option you have. So this really isn't an option for that. This is for people that have traditional Medicare. That's more along the lines of they've pre-selected a Medicare Advantage plan for you, and they're help subsidizing the cost. That's kind of the way to think of those plans. So that's actually kind of a good transition to Medicare Advantage, right? So what is this all about, right? So Medicare Advantage, so I'll show in a minute why this has grown, like how much this has grown, right? But it operates like the insurance, that commercial insurance that we've all known and loved, right, for the last 30 years or so, right? So it's operates like commercial plans, right? So you may have a PCP, depending on which options that are out there, right? You may have a bigger network, a smaller network. We'll talk about all that in a moment. Different patient responsibilities. But I think one of the things that I think is probably the biggest difference here, right, is Medicare is pretty much open, right? 99.9% of doctors and hospitals in the country accept Medicare, and there are no prior authorization requirements, right? So I'll tell you, right, working at the hospital, our registration staff, we love traditional Medicare patients. You know, doctor writes your prescription for a CAT scan, great, we'll schedule it tomorrow if we have availability. There's no prior authorization requirements, there's no jumping through hoops or anything like that. That's a real, see almost any doctor in the country, right? They'll take you for it. And there are plans that are similar to that for Medicare, but it's not as wide open, right? It's also not uniform, right? Medicare Advantage plans, right? And I looked, right, for 2022, I didn't look for 2023. There are 76 different plans in Bucks County, right? So there is a laundry list to choose from and tons of variations on a theme, right? I'm going to guess Independence Blue Cross probably has 15 different Medicare Advantage plans just in our county that are there. Each of them a little bit different, right? So, I mean, the idea behind them is they're required by law to cover everything that Medicare covers, right? So if Medicare covers it, they need to cover it. So think of that really broadly, like hospital, doctors, durable medical equipment, annual well visits, things like that, right? They're required to cover that, but there are different interpretations of what things that are medically necessary, right? And I think that's where folks like me that work on the hospital side, we kind of get into arguments over, right? If you have traditional Medicare, you end up in the emergency room, right? And the doctor says, you know what, so you show us example, you have pneumonia, you need to be admitted, right? Traditional Medicare patient, the doctor will write the order, you'll be admitted, you'll be an inpatient in the hospital until they feel you're clear for discharge. There are slightly different rules to Medicare Advantage plans. They need to cover inpatient hospitalization, but they have doctors on their side doing utilization review, right? They're reviewing the case saying, is it medically necessary for you to be an inpatient in the hospital? If not, they're not going to authorize that and you wouldn't be admitted. More likely to, now, the hospitals have a responsibility to safely discharge you. So, we argue and fight and what have you. There may be an observation type status that's out there. But things like a CAT scan, right? Again, we talked about that, or a lab work. The plans may not feel that that's medically necessary. They have their own criteria for that. So they're a little bit more restrictive on that. Something that Medicare Advantage plans do offer, though, is they can offer all sorts of other benefits, which are really valuable, especially because Medicare doesn't offer them, right? So Medicare does not cover dental, right? They don't cover eyeglasses. They don't cover hearing aids, right? Even some over-the-counter items. So some plans have things where they almost give you like a booklet, right? To sit there and say, pick out some Advil, Band-Aids, things like that you can do. All really, really valuable benefits for you. We'll talk about drugs in a minute, but most Medicare Advantage plans, more than 90%, had some kind of drug benefit with them. So pharmaceuticals are not inexpensive by any stretch of the imagination. So it could be really, really helpful to have that all in one spot for you. I'll pause for a minute. I have more to talk about for Medicare Advantage, but just want to make sure it kind of at a high level makes sense what Medicare Advantage is all about. Charlotte? Yep, Charlotte?
Okay, I have a question. Part of a discussion about a week ago. Do or don't Medicare Advantage plans pay for cancer treatment? And does Medicare pay for cancer treatment?
Short answer is generally yes, right? In a, I would say, traditional cancer treatment, right? So
Is
radiation,
that, I'm sorry, is that the Advantage plan or the traditional?
every one of them does,
Okay.
right? That are there. So like traditional, so traditional chemotherapy, radiation therapy, things of that sort, they are covered, right? Now there are caveats with all of that, right? So Medicare puts forth national coverage determination saying what things are covered, right? So Virtual opened up an $100 million proton beam center in New Jersey, right? But Medicare only covers it for certain conditions, right? So even though cancer treatment is covered, it may not be covered for what you think it is, right? It may not be covered for everything. There are also requirements, so certain non-traditional therapies for cancer are probably not covered. And especially for Medicare Advantage plans, they may really push you to different sites of service, right? So if you need chemotherapy and you're otherwise healthy, they may sit there and say this is not something that should be done in a hospital, it should be done in a doctor's office because it can safely be done there. But as a general rule, yes, it is absolutely covered under Medicare.
It was interesting because I wanted some other kind of treatment that not for cancer, and the Advantage plan, Medicare covers it, but the Advantage plans told me they don't.
So
I guess there's certain, like you say, there's certain categories of things that
there are, but again, at a broad level, right? They are required to cover everything that Medicare does, but there are nuances to that, right? They can't be more restrictive from a coverage perspective. They can be more restrictive as to where it can be delivered or things of that sort. So these are just a couple of graphs here, right? So Medicare Advantage has grown a ton, right? I don't bore you with all the details here, right? But you can look where it was, 20 years ago, right? Just overall growth of Medicare Advantage, right? Over the last couple of years, right? Medicare Advantage has been big uptakes, right? Traditional Medicare has actually gone down a little bit, not from an absolute number, but as far as where people are choosing to enroll, right? And I could probably look at that and say, hey, the plans have gotten somewhat better. But I think the reality is that as baby boomers look to retire, right, we have grown up in an environment, right, where the norm is some kind of managed care plan, right? The number of people that have a traditional go to whatever doctor you want, no authorizations are, they're fewer and far between, right? So it's kind of the norm you're used to. If you see benefits in it, it's no different than what you're doing today, right? So I think it's big uptake. This is a little bit blurry. I stole all these slides from another presentation I was on, but Pennsylvania, like most things, we tend to be right in the middle of the country, right? About half of we're in that spot, right? We're right in the middle. We're not the one end or the other. About 50% of our Medicare Advantage members, Medicare eligible patients have a Medicare Advantage plan. That's right about the national average, right? Some states are higher, some states are lower. We have relatively low uptake because we're probably at that medium point at this point. New Jersey, on the other hand, right, just go across the river, 39%, so a little bit lower, right, as far as uptake. I think part of that is just the plans that tend to sell in the area, right? So, I guess some more about Medicare Advantage plans, right? Things to think about, right? They are a great option, right? If your doctors and your hospitals are in network, right? So if you use Penn, you use St. Mary, right? Whoever, Jefferson, whoever you like, right? That's where your doctors, that's the hospital you like, and they're in network with the Medicare Advantage plan. If doesn't cost you, get additional benefits, you have broad access to it, right? There's probably no harm, no foul for doing it, right? Like, because you get to see your doctors, you get some additional benefits, and all is well in the world, right? There are also some things that works really, really well for, right? So there are some, national plans, right? Aetna, United, Humana, right? They often have like really large national networks So if you travel, right, quite a bit, and you're not worried about it, or you're a snowbird, right, you spend half the year down in Florida, they have a network up here, network down in Florida, right? No concerns about that. Even like Blue Cross plans, like, if I look at Independence Blue Cross, they have a huge network here in the Philadelphia market, but they have products which are like a PPO, right? Which will allow you to use anyone that takes Medicare. They may even have arrangements with other Blue Cross plans. So the ones that are traditional PPOs, like you pay more for them on a monthly basis, but you have more flexibility to use just about any Medicare doctor. And they probably charge you more when you visit those doctors as opposed to their tight network. So one thing I did want to mention though, even if you pick the most restrictive plans that you have, right? All of them need to provide coverage in an emergency, right? So if you say, you know what, I'm picking a plan that doesn't cost me anything, a tight network of doctors, and you're visiting somewhere and you feel you need to go to the emergency room, all of them need to provide emergency coverage, right? That's there. So that should never stand in your way. If you have a medical emergency, you should call 911, be in the emergency room. They have to provide coverage for you, right? Doesn't mean follow-up care will be exactly where you need it to be, but for that, medical emergency, they have to provide coverage. Also, all plans, right, have built-in patient protection options that are in there, right? So, if, the hospital I work for, we get into an argument, right, over whether we should be reimbursed for it or not, or how long we should be in the hospital. Ultimately, right, the providers are on the hook for that. The patients are not on the hook, for those costs that are out there, right? So you can kind of rest easier. These plans are designed, if you sign on for them, you shouldn't lose any sleep that I'm going to get a huge balance bill, right? Now, I guess the caveat with that though is that it doesn't mean you can just park yourself in the hospital indefinitely. That's out there, right? If you're safe for discharge, right, they're going to expect you to go home. But if if it's a question of whether the hospital thinks you're ready to go home and the insurance company doesn't, you shouldn't lose any sleep that you're going to get a big bill over that. One other option the plans can talk about, right, really helpful is disease management. So, I will always sit there and say your primary care doctor should be the place you go for your care. There's no question about that. But they definitely have different programs that offer different resources that can help you. So if you happen to be, a diabetic, congestive heart failure, renal disease, there are actually even plans that are designed for these things. They can offer some really, really valuable disease management programs that can be helpful to you to do better, right, in your course of your disease. So one thing I guess I want to, just kind of level set here, right? So how are these Medicare Advantage plans paid, right? So we talked about, you pay your Part A premium when you work, your Part B premium, you pay monthly. So Medicare Advantage plans, right, they're paid to provide insurance from the federal government. They get their biggest piece of their dollars, right, from the federal government. They look and sit there and say, you're this old, you live in this geography, here are your conditions that you have. We're going to pay you an average amount per month to manage these patients that are there, right? The idea from the government is they're going to take on the risk. They're going to give them a small discount. And if they can do a good job of managing you, they will make money. If they do a lousy job of managing you, right, it's going to cost them money, right? So I'll talk about in a second, like kind of how they do it, right? But they're paid monthly. In addition, depending on how well the plans perform, right? And we'll talk about STARS measures in a minute. They can get additional dollars that are out there. And then, depending on the plan you pick, you may or may not have to pay them additional money. So how they make their money, right? Ensuring they know how sick their members are, right? So the sicker you are, theoretically, the more you will cost the insurance company. So the federal government pays them more. So the insurance companies have all sorts of incentives to make sure they are accurately reporting how sick you are. And if you read the news, there's some bad headlines about how they're abusing the system, but they want to make sure that they are appropriately coding, right? They've recorded every diagnosis that you have appropriately. So their incentive is to get you into the doctor and have the doctors appropriately code for how sick you are with every condition that you may happen to have. So that's kind of their revenue side, right? Their cost side, how they try and save costs, right? It's really two things, right? It's prevention, right? To make sure that you stay well, right? And I'll talk about that in 1 second, like, what the plans have, right? To make sure you stay well. So well visits to doctors, right? Screenings, vaccinations, things like that. and utilization management, right? And that is making sure you don't use the hospital inappropriately, right? Getting authorizations and then denying stuff that they deem as not medically necessary. Doctors, hospitals, we are paid. We have financial incentives to manage these plans' patients, right? So we are, as a, we have a Virtua, right? We have a medical group, which is primary care doctors, specialists. We receive additional dollars if we do a good job of managing our patients, right? By getting them in for visits and doing well with their care. Insurance companies try and align their incentives with the doctors. So I talked a minute ago about stars, right? That's kind of how Medicare rates how good the plans are. So I'm not going to bore you with every one of these stars measures that are here, right? But you can kind of look on the screen and see, this is kind of what the, how CMS, right, the Centers for Medicare and Medicaid Services, this is what they use to kind of evaluate health plans, like how well the plans perform. I'll highlight a few in here, right? These are the things that me, the one that represents doctors, right, that we are incented for, right? We are incented to keep our patients healthy by trying to perform well on these conditions, right? So if you happen to have a Medicare Advantage plan, right, if you are, their doctor's going to actively encourage you to get your flu shot, right? To make sure you've had a colonoscopy in the last 10 years, right? If you are to test your blood sugar if you're a diabetic, right? To have an eye exam, have a mammogram, right? Things like that. The left side are medical ones. The right side are drug measures that are there, right? So if you happen to, be a diabetic, to make sure you're using statins and things like that. But overall, right, all this is kind of geared at like keeping patients as healthy as they can, right? Use the preventative metrics, keep patients as healthy as you can, is kind of the goal that's there. So again, I'll pause here for a second. It's probably a little bit in the weeds, but when they kind of rank health plans, this is the stuff that CMS is looking at, right? Like part of it is controlled by doctors, part of it is just like health plan measures, which are customer satisfaction, how quickly you answer calls. But really where their real money is like keeping patients, healthy.
Eric, where would somebody find the rankings?
I'll actually show you that in a minute, Leon. It's coming up, so hang tight.
Oh, sorry.
Yep. So, if you're thinking about a Medicare Advantage plan, right, some things to keep in the back of your mind, right? First one is like cost, right? You could have a monthly premium. Some have none, some have additional monthly premium. How does this compare to what you're paying to traditional Medicare and those supplements, right? Those supplements can be pricey, so this may be a good option for you, but you need to kind of look at the finances and see how all of them fit together. The other things are like, what if you need a specialist or facility, right? So, you look at and say, hey, great, all my doctors are network, no problem. That's great until you need a cardiologist who may not happen to be there, right? So I think it's important to look who else is in the network, even if you're not using them today, to make sure you feel comfortable that those specialists are out there. Now, I guess you can take it as a good or as a bad, right? Large medical groups tend to move in and out of network together, right? So that's a good thing, right? Like you sit there and say, hey, look, I use all St. Mary doctors, no concerns, everyone I need, all my specialists are there. That's wonderful. That's great as long as they stay in network, right? I'll tell you, at the end of actually just about this time last year, Virtua was in negotiations with Aetna and things did not go well. And we're at the end of the year where, we had 14,000 members were going to lose access, right, to their primary care doctor because all of Virtua's, doctors were going to move out of Aetna's Medicare network. We reached terms, we sang Kumbaya, everyone's happy now, right? But that's something to keep in mind that, everyone has an incentive to kind of stay in network if they can, but if they can't reach terms, you may have lost all your doctors and you're kind of locked in. We'll talk about options on that in a minute. One thing to think about is also like who's in the subacute network, right? So we always sit there and think, which hospitals are out there, but if you go to a hospital and you're going to need skilled nursing care afterwards, and you want your choice of facility that's out there, it's always subject to availability, but you want to make sure that you're looking at plans that you're not stuck in geographically a place that you don't want to be, right? Or from a quality of care perspective. Subacute network especially, right? They are also dependent upon availability. So I would, there's always choice to the extent that you can have it, right? But there's no guarantee that if you're ready to be discharged on a Tuesday, that there's going to be a bed available in the place you want to be with the level of care that you need on that day. So I think it's important to kind of look and say, how broad is the network? Do I have 4 or 5 options that seem to meet the needs that where I'd like to be? But
Doesn't the social worker or the social service person at the hospital have part of the responsibility for that? It's not just the plan?
so they do, but they have responsibility for a safe discharge for you. So if you need inpatient level of rehab, which means I think it's like 4 hours a day of, PTOT, whatever it happens to be that's out there, they need to find a place that will take you for that. It does not mean that it will be your first choice, right, of where you'd like to be. So they may be able to find you one in Montgomery County, which, okay, that's great, but maybe that's far away from your family and friends where you want to be, or one that does not to your liking, right? As far as, you visited a friend there and you're like, I do not want to be a patient in this facility, right? So I think having those options, they have a responsibility to kind of give you options that are out there, but ultimately the family gets to make a choice as to where they get to go.
But wait, how does that relate to what you said about in network or not in network?
So they will give you a list of options and say, Blythe, you can go wherever you want, but if you have Aetna's plan, for example, here are all the here are all the the ones that have inpatient rehab, but these 4 are in network with Aetna, and these are the ones they authorize. So unless you want to pay cash, which is probably on the order of $2,500 a day or something like that, right? You're going to have to go to one of Aetna's participating facilities, and here are the 4 that are out there, and here are the 2 that have beds that are available, right? So I think it's important to kind of understand who are in the network. And the other question is just, will the plan authorize, or how quickly will they authorize the care that you need, right? Your doctor tells you that, what is elective from an insurance plan perspective may not be elective from your perspective, right? And elective means they have 2 weeks to, authorize something. But, I mean, if you sit there and go to the doctor and, and said, or, I mean, let's say that, you had a mammogram, there was a finding on it, and you have to wait for an MRI, right? 2 weeks is a long time to wait for that to get authorized that's out there. Now, oftentimes that 2 weeks is the outer limit of it, right? That's out there. Things should move quicker than that, but that's generally not an option in traditional Medicare, right? So just something to keep in mind, right? That's something you're kind of, I don't say giving up, but something at least for consideration, right? If you're taking advantage of the Medicare Advantage plan. Okay, so that was traditional. That was Medicare Advantage. Before I move on to drugs, any other questions on this? So Part D is Medicare drug coverage, and this was implemented, I don't know, I guess it's probably close to 20 years ago at this point. I feel old because I remember being passed when I was like in grad school. If you have traditional Medicare, right, or a Medicare Advantage plan does not have drug coverage, which is they're few and far between, you can sign up for an individual drug plan. I'll show you about that in a second as well. I guess one thing to look at, and actually Medicare does a pretty decent job with this, you can kind of input your medicines and see what the costs are across different plans. So I think that's actually probably the best way to go about it. Generally, the way it works is that Medicare, these drug plans have to have tiers of medicines in the same class, right? So I am not a doctor, right? But like statins, right, for high cholesterol, there are a dozen whatever ones that are out there. They kind of, the individual plans will negotiate the best rates they can for them and give you the best prices on them. But that, again, only works if, it's the drug that you're on. And sometimes maybe you're indifferent, right? Maybe you can talk to your doctor. They don't care switching you from one drug to another. In other cases, like something has worked really well for you, we've had an allergic reaction to another one, you really need to make sure you stay on that and understand what's in there. I think it's also important to look at other options as well, right? There are a whole bunch of drug comparison sites, like GoodRx is one of the ones that jumps out to me all the time, right? Where you may do even better just paying cash with a coupon on GoodRx or going to a different pharmacy than you would paying through your Medicare Part D plan. So just, you have to know your options that are out there. And there are drug discount programs as well, although they limit them to Medicare beneficiaries. So just something to keep in mind that it is important to have that. especially if you retire and you're healthy and not taking anything, you're only taking a couple of generics, it may be easy to sit there and say, forget it, I don't need a Part D plan, because it's more costly for me than the cost of the drugs. Similar to other Medicare, right? If you don't enroll when you turn 65, there are penalties for late enrollment, right? It increases your monthly premium that's out there. Maybe that's worthwhile though, right? Maybe you look at it, you can do the math on it and say, it'll cost me another $2 a month. If I don't pay for the first year that I'm in here, and the penalty is that, if I live another 25, 30 years, it's worth it to me, right? It's just, keep that in mind though. There's no free lunch, as they say, right? It's going to cost you one way or another for them. Okay. So I guess I want to talk about like timing, right? So when do I sign up for all the stuff? We'll talk about in a second, how you actually sign up for all this stuff that's here. So when you turn 65, right, or your employment coverage ends, we talked about this, right, 3 months before, 3 months after, that's when you would sign up for traditional Medicare or Medicare Advantage. And the Medicare supplements at that point, right, the world's your oyster, sign up for whatever you want, all options are open to you, do it all, it's great. But now, right, so now we're in it, right, for the last 9 days or so until December 7th. This is Medicare's annual enrollment period, right? That's why we're doing this talk now, right? Anyone who's eligible for Medicare, right, you can sign up, you can switch, right? So you have traditional Medicare, you think a Medicare Advantage plan is great, feel free to switch. You want to drop your Medicare Advantage plan, switch to another one, feel free to switch, right? You want to go back to traditional Medicare, this is the time to do it, right? And this is for effective January 1st, 2024. If you switched and you sit there and say, I have a Medicare Advantage plan and you have buyer's remorse, you have a little bit of a reprieve as well, right? So January 1st through March 31st, right? If you happen to have a Medicare Advantage plan, you can switch to a different plan or traditional Medicare, right? So that's not often used by folks. Most people feel they're kind of stuck with it for the year. The times when this is used are when things go terribly awry, like I said, right? Like you renewed your Aetna Medicare Advantage plan and then virtually dropped out of, Aetna's program, opportunity to switch to another plan that's out there. There are also some other times like throughout the year for life events, right? If you happen to move or things like that, or plans lose their enrollment, but generally, right, these are the times when you have to look and say, when I would enroll for Medicare. Questions on this? So where do I look, right? So again, kind of unbiased, right? Best way to look. If you go to Medicare.gov, right? So go to Medicare.gov. If you click on Find and Compare, right? These areas over here, they have health and drug plans. So you click on this. There's also the Medigap policies as well, right? So these are not salesy. It's kind of like, tell them where you live, right? Give them some basic information about you, and they'll tell you about the plan, right? They'll tell you all your options that are available. When you are enrolling, when you click on the plans, you can see that they'll give you a high level, and then there's a ton of detail in here, right? If you choose to read through the 250-page document they have filed with CMS, you can do that. There's also like a summary plan description, which is kind of a 2 or 3 pager, which gives you a better sense that most people can hopefully understand what's happening there. That's here as well, but they give you some real high level like information here, right? So Leon, to your point, when you look at these plans, right, they'll tell you the star rating here, right? The more the better, right? Easy, that's there. There's something magical about like that 4 stars. I would sit there and say that's where every plan achieves to, looks to be. So keep that in mind. When you're enrolling though, because there are so many options, this plan ID here, right? I just picked a Geisinger plan because it just happened to be the first one that came up in the list that was here. If you're going to enroll, and be that through a broker or through the plan's individual website, you need to make sure the plan you have selected here, right? I'm pointing my screen, not that you guys can see what I'm looking at. This plan ID better be what you're signing up for, because there's so many variations that are on there. That is the bet. You want to make sure you're getting the benefits that you expected. So that's kind of their unique filing number with CMS to make sure the benefits that are here kind of line with what you have. But this is really, I think, helpful as far as to sit there and say, hey, what is a real high level? What's my monthly costs that are here? How does it interact with my drugs? What's covered here? What are some of the other benefits they have? What are some co-payments, co-insurance, right? Medicare.gov is where the place that is like kind of unbiased. once you kind of find the plan that you think you're interested in, if you do want to sign up with a Medicare Advantage plan, right, you just need to go to you can either work with a broker if that's kind of your choice, or you can just go to the individual plans websites, right? Be it Independence Blue Cross or Humana or Aetna or United or wherever they happen to be. Go to the website so you can sign up directly there, and they're happy to get you. It's just some basic information, right? Social Security number, Medicare ID, date of birth, all that fun stuff, and they'll get you signed up. So I think we touched on most of these that are here, right? So talking about sign up when you turn 65. I had a couple other things I want to mention here, right? If you're still working, make sure you understand your options. One thing here, right, especially, unlike like commercial insurance, right, where you pick up a family plan, there's no requirement that you and your spouse, if you happen to be married, right, have the same plan, right? So if you have a different set of doctors, different set of drugs, one can pick Independence Blue Cross, one can pick Geisinger, right? One could have traditional Medicare, one isn't. Like, pick which, these are individual programs, right? So don't feel obligated to pick the same plan just because you happen to be married, right? There's no requirement on that. Traditional Medicare, right, brought us coverage and access, but it's costly, right? And you don't get those additional fringe benefits, right, that are there. Medigap plans, we talked about them, right? They compete on price, but it may not be available when you get sick, so keep that in mind. But they definitely do help protect against unexpected costs out of there. Certainly, Medicare Advantage plans can be a great value if they meet your needs. Don't forget about drugs. And I guess my last final takeaway here, right, is, I am always leery, right, of anyone trying to sell you anything, right, knowing what their incentive is, right? So be it, broker, and unfortunately, even like your primary care doctor or insurers, right, they all may have a financial incentive, right? They may get paid more or have some kind of benefit for getting you to sign up. You need to be your own advocate, right? Like, I'm hoping I'm giving you at least some tools here to sit there and at least understand the universe to make the choice that's best for you. I really do hope brokers really do try and say, hey, this, given your situation, this is what I think works for you. But they clearly receive different compensation depending on which plans they sell. So even if they, offer 10 different plans, they may push you towards one where they get a better bonus for sign up. So, don't be afraid to ask some hard questions, right, that are out there. Same thing for your doctors, right? That if a doctor is trying to steer you to one plan or another, they may have an incentive to do it, right? Just, again, keep that in mind, right? Be your own advocate, try and ask some good questions. So that is all I had prepared, but I am happy I'll stop sharing here so you can hopefully see this.
Eric,
Sure.
I asked that question to one of the brokers' presentations about their fee. And this broker said that these supplemental insurances pay the same amount as required by law, so that they do not push for a particular insurance because of the incentive. Now, could he have been lying? Of course, I don't know the guy, but that's what he said publicly, that the brokers get paid the same amount regardless of what insurance they encourage. The other thing I wanted to mention is another broker was asking about medication. And I asked her, why are you asking about which medication, I take or my husband takes? And they said, because not all of the insurances will include those particular medications. And they said, so if it's a very expensive medication, I need to make sure that the insurance that I'm going to recommend would include that. So I just wanted to point that out to people who are looking to use a broker.
Yeah, so Barbara, I am not a broker, and I know there are regulations around it, but I also sit there and say that there are opportunities for, I'll call it like horse trading, right? So maybe they are limited what they can do for Medicare, but they may have a little bit more freedom on what they could do with the commercial products as well, right? So there still may be that benefit that's out there. And so I think there are definitely regulations around it. I'm not an expert on it, but I guess I would say advocate for yourself. On the medications, I would say 100%, right? The plans look at it and they say, need to have coverage in a class of drugs that are out there, right? So again, it is really important that whoever you're dealing with, again, if you're doing it on your own, you just want to make sure you're entering your drugs into the website that's out there. There's sometimes questions, whether you accept the generic or you need the brand name that's out there. But it is incredibly important, especially if you are on a specific, it's not available on a generic, to really know what that is, because those costs between those tiers, right, could be difference between a $5 copayment and several $1,000s in cost right over the course of the year. So it is incredibly important that that information be shared. Any other questions? Gotcha.
So I just have a comment, they're all push on TV for, oh, you have A, B, and D. You probably want to get C, blah, 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 blah. Why would somebody, if they have D, want C? And can you also have both? I mean,
yeah, so I think their pitch is that you're paying for all these individually. You can get them all bundled into one plan. And even I actually say from a disease management, patient management perspective, there is some benefit to doing that, right? So like when we get reports from insurance companies, right, as far as how well we're doing managing patients, and they can actually share some data with us, right? So we can, if we are, like, for example, I'll use Aetna again, right? If you happen to have Aetna's drug benefit as well, right, and they've diagnosed you as a diabetic, they could sit there and say, hey, Charlotte has not filled these prescriptions. We see it from our drug benefit, right, that's out there. I think their pitch to patients is really like, hey, you're paying for all these things individually anyway, bundled together, get better value that's out there. But and there are some Part C, Medicare Advantage Part C plans that don't have a drug benefit, but it's the minority of them. It's like less than 10% nationwide. I've not checked specifically for the our Bucks County area to see how many are out there. But I think it's more of you're paying for it, you perhaps get better value here. I think that's kind of their pitch.
This wasn't instead of, this was an addition to, I thought.
So I mean, again, you could have a part if you're paying for A, B, and if you're paying for A and B, you probably want D if you want to have drug coverage that's out there. But if you opt for Part C, you have replaced A and B, I guess is how I'll put it.
Okay, because it's kind of confusing when you listen to these commercials.
Yes, I think to a certain extent by design, right? Okay. Well, again, I thank everyone for your time today. Hopefully, give you something here to kind of chew on. Happy, if there's something here that's not clear or want copy of the slides, feel free to reach out. Happy to kind of share. Helene, this is recorded, I guess, so anyone can feel free to view it again, right, once this is posted. But again, appreciate everyone's time. Feel free to reach out with questions.
Appreciate your time very much. Thank you.
Thanks,
It was
Eric.
Really
Thank you
very
very
good and
much.
informative.
Thanks, everyone.
Really
Thanks, Eric.
appreciate it, Eric. Thank you
My
so
pleasure.
much.
Thank you.
Thank you.
Great job.
Good night,
Thanks,
everyone.
Helene.
Hi, everybody.
Good night,
No
everyone.
problem.
Yes,
Good
thank
night,
you,
everyone.
Thank
See you
you.
soon.
Good night.
Go Phillies.